I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Welcome to the January 8th, 2025 regular meeting of the Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, Shirley,
yeah, I know. Shirley.
Please take the roll.
Yes. Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present.
And Director Eapen?
Present.
Thank you. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record and proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting?
Not at this time.
Thank you. Shirley, are there any written communications?
No. Not at this time.
Okay, thank you.
Wait.
All right. We are going to be moving to the consent calendar, which consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar item A?
I move that the Board of Directors approve the consent calendar item A.
Thank you. Would you please take the roll?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
And Director Eapen?
Aye.
Thank you. We are now going to move on to the medical staff report. Dr. Oh, no?
Yeah, there, we have
There
Dr.
he is.
Slay.
Yeah,
Good
hi.
evening.
I was just in the ER. Good evening and Happy New Year, everyone.
Happy New Year.
All right, so I'm going to give you the medical staff census. We have a grand total of 665 members. Of those, we have 362 that are active, about half, 2 administrative, 36 advanced practice providers, 97 ambulatory, 9 consulting, 11 courtesy, 1 who's on leave of absence, 92 provisional active, 12 provisional advanced practice providers, 42 provisional consulting, and 1 temporary privilege. Regarding my report, we have the general medical staff meeting coming up next week. That's Tuesday the 14th. The dinner dance, the annual dinner dance at the end of June. We are still looking for candidates for the election. That has to happen before June for the new slate of medical staff leadership. Of course, as you know, we're dealing with the continued high census at the hospital. It's just a very busy time right now. And then the new logo, mission, and vision and values that's being updated, that is going to be taken up by the medical staff, changing our logo, the letterhead, etc. And the same will also be used across the street at the Washington Outpatient Surgery Center. The aquablation program continues to go very well. I did 2 cases this morning that went very smoothly. The staff is doing a great job in the OR with that. And I believe that is all I have, unless somebody has any questions for me.
Any questions, anyone? Okay, well, thank you. Happy New Year to you too, Dr. Saleh.
Thank you, everyone. Have a good evening.
Thank you. Okay, we'll now move on to the Service League report from Sheila.
Good evening, members of the district board. Again, I extend a warm greetings and a very happy new year to all of you on behalf of all our volunteers as we step into 2025 with fresh perspectives and continued dedication. I'm pleased to report that in December, 249 Service League volunteers contributed a total of 2,176 hours across various hospital departments. In the coming weeks, we will begin training volunteers to assist in the wound clinic. This new opportunity will allow volunteers to provide valuable support to patients and staff in this vital area of care. During Christmas week, the volunteers distributed more than 250 individually packed activity kits to patients, providing a source of joy and comfort during the holiday season. Each pack was assembled with coloring pages, Sudoku, word search, and crossword puzzles, along with crayons and pencils to encourage creativity and mental engagement. Volunteers also distributed over 200 individually packed handmade scarves to patients. These meaningful gestures helped brighten the spirits of patients, offering them a moment of respite and a festive touch that was genuinely appreciated by them. The feedback we received was overwhelmingly positive, and many patients expressed how these small tokens made their stay feel a little more special during the holidays. I'd like to share a heartwarming update about Doris Westbrook, a former volunteer who recently reached out to us. She shared how much she misses being an active part of our volunteering team and fondly remembers her time at the main hospital lobby desk where she greeted patients and visitors. Although Doris retired from volunteering in 2019, she mentions that if it weren't for her age, she's now 103 years old, she would still be serving with us today. Her dedication and love for our hospital community continue to inspire us, and we are deeply grateful for her years of service and also for keeping in touch with us. Volunteers are eagerly anticipating the upcoming annual Service League Business Meeting and Luncheon on Tuesday, February 18th. This event will provide an opportunity to reflect on the achievements of the past year, discuss upcoming initiatives, and recognize the valuable contributions of our dedicated volunteers. Invitations for the luncheon will be sent out shortly, and I hope to see all of you there to celebrate our success. That's the end of my presentation. Please let me know if you have any questions.
Thank you. Thank you, Sheila. Any questions? Okay. Happy New Year to you as well.
Thank you very much, Mr. Wallace.
Okay, Kimberly, we're going to move.
Yes, this evening we have the annual critical care program update, and I believe that Dr. Cyrus Chariot is going to be the presenter this evening. I would just give you a little bit of a background. Dr. Chariot was raised in the Bay Area. He attended UC Berkeley for his undergraduate studies and UC Davis for medical school. After finishing his critical care training at New York University, he returned to the Bay Area and has been working at Washington Hospital since 2011. He is board certified in critical care, pulmonary, and neurocritical care medicine. Currently, Dr. Chariot is the co-medical director of the intensivist program, critical care unit, and intermediate care unit. He also serves as chair of the PNT and bioethics committee at Washington Hospital. I do see that also Dr. Omid Azizarad is also on this evening, and he is the other co-medical director of the intensivist program. So welcome to both Dr. Chariot and Dr. Azizarad.
Thanks for having us. Before I start the presentation, I want to say it's unique being in a co-medical director situation. Once Carmen retired, Omid and I became co-medical directors, and it's been a very good collaboration. We both have our strengths and weaknesses, and there's a lot of communication between us throughout the year, in person, in text, by phone, by email. And it got to the point where we communicate so often that Dr. Azizarad's smartphones thought that we were a couple. And
So smart.
So it began to, when he would go grocery shopping or he would leave his home, it began to remind him to tell me where he was going. And that kind of highlights our co-directorship. Okay.
Too much time together.
So we can get started. Okay, briefly going over the history of the ICU program. Established in 2008 in the old building, our 20-bed ICU, and staffing was increased by the following year to allow a 24/7 presence of the intensivists in the ICU. And in 2016, of course, the board approved the intensivist-led critical care model. This essentially was the transition to a closed ICU, where we were no longer consultants, but the primary physicians for all ICU patients. And 2 years later, in 2018, we moved to our current larger ICU in the Morris Hyman Pavilion. Next slide. The intensivist-led model, our mission is to provide 24/7 coverage for all patients in the ICU and consultative services for critically ill patients across the hospital. We have 2 critical care patients working 2 12-hour shifts a day. We have 9 full-time physicians and 7 part-time physicians, and all of us are critical care board certified. But we do have a variety of different training backgrounds in addition to critical care. 10 of us are internal medicine trained, 7 pulmonary, 2 neurocritical care, 2 emergency medicine, 1 anesthesiologist, 1 nephrologist, and 1 is trained in sleep medicine. And the physician trained in sleep medicine actually only does night shifts, which is ironic because if you talk to a sleep doctor, they will tell you the worst thing for your sleep and your health is to work at nights. But next slide. What are our goals? We want to provide timely, high-quality, evidence-based critical care services. We want to collaborate with a multidisciplinary team to optimize patient outcomes. We also try to engage in regular education of staff, including evidence-based standards of care and clinical reasoning skills. And we also hope to engage proactively with families to keep them updated on their loved one's condition and to help facilitate decision-making. Next slide. This is the number of ICU admissions over the past several years. You can see there was a steady decrease over the past 4 or 5 years, but this year we increased 1,270 admissions in 2024, which is a 9% increase from 2023. And we anticipate this will continue to go up in 2025. Next slide. Let's talk about some of our quality initiatives. So the multidisciplinary rounds in the IMC and ICU, this is based on an evidence-based liberation bundle. It's called A to F Liberation Bundle from the Society of Critical Care Medicine, which is aimed to improve outcomes. And essentially a bundle is a checklist of things that you go over to help optimize care. So we collaborate with essentially all departments that take care of critically ill patients. And we go through this bundle, which I'll show in the upcoming slide. We've actually extended our bundle from A to F to A through H. And some of the big benefits of this have been minimizing sedation and the ventilator days, promoting early removal of devices, and we'll go over these metrics in this talk, and early detection and treatment of delirium. And can we move forward actually 2 slides? And this is, for those of you not familiar with it, this is the A through F bundle, and we added the G and H. And the G is glucose, making sure the glucose is well controlled. Also for G is get lines out. So removing lines in a timely fashion. This includes central lines, drains, Foley catheters, etc. And we added H to make sure the ICU patients all are getting adequate oral hygiene. And the other H is hospital-acquired wounds. So keeping a close eye on those and getting wound care involved as needed. Previous slide. Another quality initiative has been the quarterly critical care case studies. And every 3 months, I choose one case that was challenging, taught us something important, and create a presentation for a broad audience, basically anyone who will take care of critical care patients, actually anyone who takes care of patients. And we try to go over things that'll improve the knowledge base of the audience, improve clinical reasoning skills, and teach a little bit about evidence-based medicine and standards of care. I gave a community lecture about sepsis awareness, which is available on our YouTube channel. And during Critical Care Awareness Month, Dr. Morrison this year in May spoke about massive transfusion, a very relevant topic, especially now that we are a trauma center. Next slide. And next one. Another change, which actually began in July of 2022, was intensivist-led code blues. To give some background, we would go to the code blues in the ICU prior to this change, and the emergency room doctor would go to the code blues throughout the hospital, and we became the primary responder to these code blues. Which I think has been beneficial in a few ways. There's fewer interruptions in the care and triage in the ER because the ER doctor doesn't have to run across the hospital and run the code blue. But also there's improved patient flow and continuity of care. And what this means is if a patient survives a cardiac arrest and a code blue, they're naturally going to come to the ICU. And now the same person who resuscitated them and went to the code blue and knows all the details will continue to take care of them in the ICU and often, accompanies them to the ICU once they're resuscitated. So better continuity of care. Next slide. This is our top 5 admission diagnoses for the past 3 years. And the top 5 is actually 5 of these 6 diagnoses here. Now our top 3 are respiratory failure, status post cardiac surgery, CABG, and sepsis. And then the other 3 are STEMI, which is a heart attack basically, requiring urgent care, cerebral infarction or strokes, and cardiac arrest. And the top 5 has been 5 of these 6 for the past 3 years. We hope to stratify our metrics in the coming years to look at specific diagnoses. Next slide. So going over our metrics. So this is critical care mortality. The orange lines are the Society of Critical Care Medicine benchmark. And, there is a variety, 10 to 29%, because mortality depends on a lot of factors, including what type of ICU you are, surgical, medical, or mixed, as well as how sick your patient population is. And obviously, the quality of care also factors in. Our internal benchmark is significantly, I'm sorry, there's no internal benchmark on this slide, but anyway, as you can see, our mortality rate is really on the low end of the benchmark. It's pretty good. It's close to the lower end. This past year, it was 12%. And, a lot of mortality in the ICU is patients who get transitioned to comfort measures only, palliative care intervention. And obviously, that doesn't reflect the quality of care at all. That's just a change in the goals of care. And we thought it would be good to look at our mortality if we exclude the comfort care patients, and it's actually quite low. Looks like 5.5% this year. Next slide. Our length of stay is also quite good. The internal benchmark is 4.9 days, and I believe that's coincides with the national average. Length of stay is also a complex metric. It depends on the types of patients you're seeing and the severity of illness. It also depends on if you're providing good, efficient, evidence-based care and also the bed flow of the hospital. But we're staying significantly below the benchmark. There's been an improvement compared to 3-4 years ago, or 4 or 5 years ago. Next slide. Our ICU readmission rate is something we're proud of. This is people who are transferred out of the ICU and become sick and have to come back within 24 hours. And so the gray line is the national benchmark of 14%. We have a pretty ambitious benchmark of 4%, which means we want 1 out of 25 patients or less that leave the ICU to come back. And I was actually surprised when I saw this. This year we had a 1% ICU readmission within 24 hours, which was lower than I expected. That means 1 out of 100 patients. So the readmissions we do look at, Dr. Azizarad and I, and most of the times they are non-preventable events. Most of the time it's a very frail patient who gets better than gets worse, rather than a premature transfer out of the ICU. Next slide. So this is our ventilator outcomes. Probably the most important one is the duration of mechanical ventilation, the median duration. And the benchmark and the national average, if you look at studies, is 5 days. And we're at 2.1 days, and we've actually been pretty good since 2018 when we became a closed ICU. Reintubation. So this is a patient who is extubated and within 24 hours is reintubated. National benchmark is 10%. So it's generally considered acceptable that 10 to 15% of patients who are extubated are reintubated. And why is that considered acceptable? Because it implies that you're being aggressive with trying to get people off the ventilator, and that failure rate is acceptable. And if the failure rate is lower than that, then probably you're keeping people on the ventilator too long. So there's a tension between mechanical ventilation duration and reintubation rate, but we're proud that both of these have actually remained low. Unplanned extubation is usually when a patient becomes very agitated, a lot of times unexpectedly, and pulls out the endotracheal tube. And we are below the national benchmark of 5%. We're actually 1% this year, which was pretty good. Next slide. CLABSI is central line associated bloodstream infection. And just to go over some acronyms for those that may not know, SIR is basically standard infection ratio, and this is based on the type of hospital you're at. What is expected would be 1. An SIR greater than 1 means something is happening more often than expected. Less than 1 means less often. SUR refers to how often you use something, like a central line. And 1 is really what's expected for your type of facility. less than one is less, and more than one means your use is more than is expected. So if we go to the SIR and the number of catheter-related infections, we haven't had any since 2022. And SIR has been less than 1 since 2019. So we've really gotten better at getting lines out and also being sterile, and the nurses have done a great job keeping an eye on them, keeping them clean. And the SUR is our use of central lines, and we're at 1 right now. We have some things in place that we want to get it significantly below 1. So we're working on that. But that's the expected amount that you would expect our ICU to use central lines. Next slide. So CAUTI is a catheter-associated urinary tract infection. This was a big project that we worked on in the past several years because our numbers were kind of high. You see the SIR was quite high in 2018, 19, 20, 21. And we set up multiple things in place to lower the usage of Foley catheters in critically ill patients. If you look on the below table, that's the SUR. So the top one is how often did we have these infections. The bottom one is how often did we use Foley catheters. So our program included having very sterile precautions and cleaning the area, having the nurses keep a close eye, but more importantly, not putting in Foley catheters reflexively. So this was a culture change in critical care, and taking them out when no longer needed, and using just a straight catheterization. So putting if someone couldn't pee, just put a tube in and drain their bladder. Even if you do that multiple times, it's less of a risk of infection. We also became more cautious about sending a urine culture at the wrong time, so that colonization with bacteria was not misinterpreted as an actual infection. So anyway, you see that the interventions have been pretty good. Our CAUTI's SIR was well below 1 in 2024. We've been ambitious. We're lowering the internal goal, it looks like, to get to close to 0. That'll be tough to achieve, but I feel like if we can stay below 1, that's a good victory. And the Foley use now is way below 1. So it's half of what's expected, half of the SUR of 1. And hopefully we can keep improving that. Next. The Press Ganey surveys that go out to patients and patients' families after their ICU or hospital experience. So we have the raw scores here compared to the gray, which is the Press Ganey benchmark. And our raw scores have been pretty good the past 3 years, above 90. And that's the likelihood to recommend the ICU. The overall ICU scores have also been pretty good. And in the future, we can also give percentages to see where we stand compared to other hospitals, because this is a raw score. So looks okay for now, but we'll be graded on a curve next year. Next slide. So for DEI, one project that we took up was being more proactive with using our interpreter services. We have a pretty good interpreter service now. We have these video tablets on wheels with a video, multiple languages, easy to access. So admittedly, when it's very busy, sometimes we didn't use it when we should. So this year we made a modest improvement compared to last year. That's a 9% improvement, and we hope to increase this more so that every patient gets optimal communication, or patient family members that don't speak English Sometimes we do have a nurse that speaks the language come and help, but it is best to use an interpreter. Next slide. This slide just underscores the diversity of our patient mix in Fremont. Next slide. So trauma program, we became a level 2 trauma center in July. We are the primary doctors for trauma patients who are admitted to the ICU. And we collaborate with the consulting trauma surgeon and other consulting services. So if you look at the top pie chart, you'll see, and I believe this was data up to December 20th, 2024, there were 907 total trauma activations. 8% came to the ICU, and that is 76 over less than 6 months. So that's actually 12 to 13 a month trauma patients coming to the ICU. And then the bottom pie chart says their percentage of likelihood of coming to the ICU depending on the type of trauma alert. Obviously, alphas, almost half of them came. The next level, Bravos were 10.5%, Deltas 8.9%, and the NSA, there wasn't actually a trauma call, but ended up getting trauma involved. Close to 4% ended up in the ICU. Next slide. So future steps, we hope to have ongoing clinical education and including more simulation-based teaching and learning. Hope to collaborate with the trauma team as well as our structural heart team and neurosurgical programs to grow those programs. It was challenging to get all of the proper data for this presentation. So we hope to make that more streamlined and efficient and maybe even, as I said earlier, give even more nuanced statistics stratified by diagnosis and stratified by severity of illness. And both of us now can take your, also billing. We are working on improving our documentation and optimizing our billing practices. And now we can, me and Dr. Azizarad can take your questions.
Any questions, anyone?
Yeah, Cyrus, this is Bill. You're 6 months into the trauma journey in the ICU. So I wonder, 2 questions. Wonder if you could just comment on how that's changed your activity and the culture within the ICU. And the second, the corollary of that first question is running a trauma case is a lot different than running medical ICU patients. And what have you been doing to get the team up to speed in dealing with the trauma patients?
Those are good questions. And I don't know, Omid, do you want to go first? And I can add something if my input too?
Yeah.
Go ahead.
So a few things. So when we first started, it was kind of difficult because it's a whole new system. The nurses were kind of at times confused who to call. Do they call us? Do they call trauma? So we got together with the trauma team and we said if there's an issue, call us directly. If they can't get a hold of the trauma doc, because sometimes the trauma docs are in the OR, right? And if there's multiple traumas come back to back, it's tough to get a hold of somebody. So we basically filter most of the calls, and then let the trauma guys handle the initial phone calls. So it's been initially it was kind of tough the first couple of days, couple of weeks. But I think it was all growing pains. We were trying to make sure that everyone communicated properly. But that was the only hiccup we had in the beginning of the program when we first started. But everything's been pretty well at this point.
Yeah, I think that's definitely I agree with Omid on that. We feel a lot busier, of course, because some of these patients are very sick and ended up staying for a long time, especially the patients with traumatic brain injury. In terms of learning, well, we did some seminars and some online things, and we all did our own reading. But to be honest, the true learning is actually taking care of the patients. So a lot of it is learning on the job. And with each sick trauma patient, I usually learn something new from my colleagues. And obviously, there's stuff that with medical ICU, we feel like we know mostly everything there is to know, but we're humble and we know we're still learning stuff. And if we don't know, we talk to our trauma consultants. And I think our group has adapted well. And I think we're busy enough and have enough ICU trauma patients to continue to improve our knowledge base and our care of them. I don't know if that answers both your questions, Bill.
Yeah, a bit. I'm just glad to see that you're learning and that you're having the seminars to share your learning, because I think we have to be a learning institution.
Yeah, no, I agree. And I actually, with regards to the case studies that we do, I actually ask Dr. Morrison to sometimes do a trauma case study so all of us can learn. He did one a few months back, and I'll ask him to do another one in 2025, or if there's interesting cases, maybe more than one. And the nurses have adapted really well too. I've been impressed. They had more of a systematic training, and they adapted pretty well.
That's all really good news. Thank you, Cyrus and Omid. Keep up the great work.
Yep.
Thank you.
Thank you. Any more questions? All right. Thank you, doctors. Thank you very much.
Thank you.
Thanks.
Thank you.
Bye.
Okay. All right, Kimberly, we're going to move into the finance.
Yes, we're going to start with November, and I'm going to turn it over to Tom McDonough.
All right, present the final hospital operating numbers for the month of November. Inpatient average daily, inpatient average daily census was 168.8 on a budget of 178. So we're off just over 9. Discharges, the third line down, we came in at 876 on a budget of 1,026 for a shortfall of 150. On a year-to-date basis, however, we're at 4,700 on a budget of 4,900, so we're only off by 200. Patient days came in at 5,064 on a budget of 5,347. And on a year-to-date basis, we're at 24,059 on a budget of 1,900. Outpatient observation equivalent days came in under budget, which is a positive, at 392 versus a budget of 400. And on a year-to-date basis, we are also under by 95. Average length of stay came in 27 basis points under budget at 4.94 on a budget of 5.21. And on a year-to-date basis through November, we are 18 basis points under budget of 5.34 at 5.16. November 24, we'll start with the case mix index coming in at 1.594 on a budget of 1.481, or just over 11 basis points of outperformance, if you will. And on an actual basis, year to date, we're sitting at 1.62 on a budget of 1.6. So almost 6 basis points of higher case mix index than the budget. Deliveries came in at 126, or 8 off the budget of 134. And on a year-to-date basis, we stand at 676, or 28 more than the budget at 648. Surgical cases, 511 on a budget of 539, so about 28 off. And then on a year-to-date basis, we are sitting at 2590 on a budget of 2599, so just 9. Cath lab cases came in 20 off at 190, a budget of 210. And then on a year-to-date basis, we are now off 15. We were positive on a year-to-date basis until November at 964 versus a budget of 979. Outpatient visits came in at 8,100 on a budget of 8,800. And on a year-to-date basis, we stand at 43,900 on a budget of 44,100. Emergency visits came in at 4,913 on a budget of 5,349, or a shortfall of 436 to budget. And on a year-to-date basis, we're off budget by 1,725. The details behind both surgical and cath lab cases. On the surgical side, ortho came in 13 above budget at 206. Cardiac surgical came in 6 above budget at 15. And endo came in 15 above budget at 129. In the cath lab, peripheral vascular and neuro IR were both above budget at 5 above budget for peripheral vascular and 7 cases above budget for neuro IR. Continuing with operating indicators on productivity measures, the productive FTEs came in at 1,463.4 on a budget of 1,493.8, or under by 30.4. And the non-productive for the month came in at 177.2 on a budget of 235.8, or positive by 58.6. So total FTEs for the month, 1,640.6 on a budget of 1,729.6, or a delta of 89. The FTEs per adjusted occupied bed underperformed the benchmark by 14 basis points, coming in at 5.9 on a budget of 5.76. And on a year-to-date basis, we are underperforming the benchmark by 22 basis points, coming in at 6.03 versus a budget year-to-date of 5.81. Okay, gross revenue for the month came in at $221,200,000 on a budget of $219,000,000, or outperformance by $1.6 million. On a year-to-date basis, we are outperforming by $11.3 million, coming in at $1,100,000 versus a budget of $1,078,000. Contractuals came in over budget at 76.13 versus a budget of 75.29 on a monthly basis. And provision of bad debt did increase during the month in charity care for the month of November to $4.5 million on a budget of $4 million, or 2.02% versus a budget of 1.84%. So all in, our total deductions came in at 78.15 versus a budget of 77.13, or 102 basis points over the budget. However, on a year-to-date basis, we remain close to budget at 77.11 versus a budget of 77.06. Okay, moving into the summary of operations. For GASB, again, GASB stands for the Government Accounting Standards Board. Net operating revenue came in at $52 million on a budget of $51.6. So $350,000 of outperformance on net operating revenue. Operating expenses, however, came in at $53,400,000 on a budget of $51,200,000, or about $2.3 million underperformance. This was mostly in professional services, so accruals for the call pay and directorship, as well as some one-times for the valuations that we did on the oncology and the other JV, and then an accrual for the anesthesia contract. So, where did that leave us on net operating income? The negative $1.5 million on a budget of positive $425,000 means we missed budget by $1.9 million. On a year-to-date basis, however, our NOI turned negative to $250,000, and that's the first time on a year-to-date basis in the fiscal year, on a budget of $800,000. So net operating margin for the month was negative 2.9, and on a year-to-date basis, it is negative 0.1. When we move down to non-op income, the month of November, we had $1.9 million on a budget of $600,000, so $1.3 million of overperformance. And on net income, then, when we add operating income and non-operating income together, we are positive $441,000 on a budget of $1 million. So we're off $570,000. However, on a year-to-date basis, we continue to outperform the budget. We are at $8.7 million on a budget of $3.8 million, or $4.8 million of outperformance. And our margin for the month there, percentage-wise, is 0.9, and on a year-to-date basis, we're sitting at 3.4% on net income. Now on the FASB standpoint, so this is, again, the Federal Accounting Standards Board, this is subject to FASB. You can see the changes really are reflected in line 5, where the net operating income is now negative $2.2 million on a budget of negative $200,000. So we trailed that by basically $2 million. And then on a year-to-date basis, we are negative $3 million on a budget of negative 2.4. When we move down to net income, we are negative $955,000 on a budget of $658,000. So we're off by $1.6 million. And net income year-to-date, we're at 1.9 on a budget of 2.1, or $200,000 off budget on that. And then finally on line 6, EBITDA for the month of November came in at $2.1 million on a budget of $3.9 million, $1.8 million shortfall. However, on a year-to-date basis, we stand at $17 million on a budget of 18.2. So $1.2 million off on a year-to-date basis. And when you look at the 1.8, year-to-date we were, up until November, we were tracking to our budgeted number of $45.4 million. So very different contrast compared to last year. And with that, I report to
Tom? There was some federal grant revenue, $800K, that was on the budget but not realized. That was the last slide. No, grant relief.
Yeah.
Yeah, it is. 879 versus 383.
Oh, yeah.
What's that?
So,
And will we get it?
it's FEMA reimbursement.
Okay.
So, the approved claim paid.
Are we gonna get it, or?
Yes.
It's budgeted for 879, so is that, I know that,
We haven't
do we
received
have,
it yet.
yeah, have we received it? Yeah.
Yes, that is what we've booked because we've been, it's been obligated.
Yeah.
Just hasn't been paid.
All right, okay, so
There
it
is-
will
yeah.
come in.
My apologies, yeah. I was looking at the 879.
I think this year is the last year that we'll see, this is the last year that we will see any of the
Any of FEMA money.
right,
Yes,
we've been putting money, we've been allocated expenses, but I think they pretty much are closing us out, yeah,
Yes.
okay. Any other questions for Tom?
No, go ahead.
All right, I want to give the preliminary statistics for December. December was a busy month for us. Patient gross revenue of $230.1 million for December was unfavorable to the budget of $231.1 million by $1.07 million or 0.5%. That was higher than December of 2023 by $14.5 million. I do want to stop and say that the $230 million in gross revenue is the most that we've seen in gross revenue in the last 5 years, and the budget of $231 is also the highest that we have budgeted to. So, yes, we came under budget, but it was still a very busy month for us in terms of it. Moving on to trauma cases, we came in, had trauma cases of 168 for December, which was favorable to the budget of 121 by 47 or 38.8%. And year-to-date cases were favorable to the budget by 267 or 40.9%. Again, we continue to see the trend. The inpatient trauma cases of 65 for December were unfavorable to the budget of 80 by 15 or 18.8%. And outpatient trauma cases of 103 for December were favorable to the budget of 41 by 62 or 151.2%. Moving on to the activation codes, trauma cases for December totaled, again, as I mentioned, 168. With the following breakdown, we had 13 alphas, 39 bravos, and 116 deltas. You can see year-to-date, 60 alphas, 283 bravos, and 571 deltas. We are now, you can see there is 4 cases that on the year-to-date that are identified as no notification. We do need to capture those that have no pre-arrival activation. So they are trauma, but they either come by their own 2 feet or car or other ways from that. Also, just to mention, in December, out of the 168 trauma cases, 70 were falls, so still see a majority of falls, 36 motor vehicle crashes, 7 body injuries, and 55 other cases. Moving on to our trauma gross revenue, came in at $20.1 million for December, which was favorable to the budget of $16.3 million by $3.8 million or 23.2%. Inpatient trauma gross revenue of $14.8 million for December was favorable to the budget of $14.6 million by 0.2 or 1.7%, despite having the lower number of cases. So we were, again, as mentioned, we were off 15 cases or 19%. And this is just due to given the mix of types of trauma cases we saw that were inpatient. Outpatient trauma gross revenue of $5.2 million for December was favorable to the budget of $1.7 million by $3.5 million or 208%. Looking at our inpatient gross revenue, it came in at $136.8 million. Again, very high for an entire year, was unfavorable to the budget by 5.72 or 4%, but $7.5 million or 5.8% higher than December of 2023. The unfavorability in December was mainly from ancillary services in terms of drugs sold to patients, respiratory, and we did offset that by increases in CT scanner and cath lab. Moving on to the outpatient gross revenue came in, gross revenue of $93.2 million was favorable to the budget by $4.65 million or 5.3%, and $7 million or 8.1% higher than December of 2023. Year-to-date revenue was favorable to the budget by $17.6 million or 3.3%. Favorable performance in December was mainly driven by the emergency department, and you'll see that, and also along with surgical services. Looking at our inpatient average length of stay came in at 5.48. It was unfavorable to the budget of 5.39 by 0.09 or 1.6%, but was favorable compared to December of 2023 by 0.29 or 5%. I do want to say that we had 13 patients with average length of stay greater than 30 days that were discharged this month. So, and we had the longest stay was 60 days. So we had some longer lengths of stay and that were discharged in this month, which is driving up the average length of stay. Looking at our average daily census, came in at 173, which was unfavorable to the budget of 187 by 14 or 7.5%, and lower than December 2023 average daily census of 175.5. I will say that as I mentioned, we had 15 less inpatient trauma cases that impacted that average daily census. As I said, we had 15 cases that equated to a budget of 242 days that we didn't see. In terms of discharges, December discharges of 1,056 were unfavorable to the budget of 1,081 by 25 or 2.3%, and year-to-date discharges were unfavorable to the budget by 231 or 3.9%. Again, looking at patient days, that trend came in at 5,363. They were unfavorable to the budget of 5,797 by 434 days or 7.5%, and were 1.4% unfavorable to December of 2023. There were 377 days for trauma patients, but again, that was unfavorable to the budget by 272 days or 42%. Looking at our surgical trends, we did have a busy surgery month, even though there were the holidays. Total surgeries in December came in at 567, which was favorable to the budget of 548 by 19 or 3.5%, and were 77 or 15.7% more than December of 2023. And year-to-date, cases were favorable to the budget by 10 or 0.3%. Our inpatient surgeries of 260 were unfavorable to the budget by 24 or 8.5%. Outpatient surgeries at 307 were favorable to the budget by 43 or 16.3%. Moving to the next page, you can see in terms of our surgical activity, as you can see, we were continued to be busy in orthopedics. We had our UCSF ortho surgeons did 63 cases this month. Also, vascular endoscopy were above budget. You can see neurosurgery, cardiac, and other surgeries were below budget. Moving on to cath lab, our December cath lab cases of 182 were unfavorable to the budget by 15 or 7.6%, but were 36 or 24.7% more than December of 2023. Year-to-date cases were unfavorable to the budget by 30 or 2.6%. In terms of cath lab, our inpatient cases of 94 were unfavorable to the budget by 21 or 18.3%, and outpatient cases of 88 were favorable to the budget by 6 or 7.3%. Next, you will see the breakdown in terms of our cath lab activity. Cardiac non-vascular pretty much on budget. We did see, the peripheral did not meet budget. We did see a number of our vascular surgeons did not meet budget in terms of their cath lab procedures this month. Neuro IR continued to be busy at 8 cases versus a budget of 5 cases. Moving on to deliveries, the month of December was busy. We saw 146 deliveries, which was favorable to the budget by 16 or 12.3%, and were 9 or 6.6 more than December of 2023. Year-to-date deliveries were favorable to the budget by 47 or 6%, and favorable year-to-date last year's year-to-date by 8.6%. We did see C-sections at approximately 48 or 32.9% of total deliveries. Moving on to non-emergency department outpatient trends, non-emergency outpatient visits of 8,356 were unfavorable to the budget by 226 or 2.6%, but more than December of 2023 by 302 or 3.7%. We did see lab visits were down in terms of really slow given the holidays on Wednesday. We saw both a lot of Thursday and Friday were below budget. Diabetes education was also below budget given the holidays, and also challenges with patients wanting to be scheduled during the holiday weeks from that. Our prenatal diagnostic clinic, however, was busy. It was 20% over budget, along with our infusion center that was also above budget by 8%. Moving on to our emergency room. This month's volume, you can see, came in at 5,614. They were favorable to the budget by 252 or 4.7%, and were 484 or 9.4% more than the prior year. And this is the highest, I believe, we've seen in the history of our organization in terms of emergency room visits. So very busy. We saw a lot of the level 4, 5, and 6 coming over budget, and so really seeing a lot more sick patients coming through the emergency room this month.
That's in addition to trauma, or?
Well, that includes the trauma. It includes trauma. So yes, that's also driving it up from that standpoint. All right, in terms of gross revenue recap, as mentioned, overall we came in 0.5% below the budget. Surgical services came in at 0.9% more than budget in terms of gross revenue. Cath lab came in very close to budget in terms of gross revenue, though cases were 7.6% unfavorable to budget. Room and board did come under budget by 5% or $2.5 million, and a lot of that, some of it had to do in terms of trauma. Also, birthing center came below budget, though they were above budget in deliveries due to the complexity of the cases. Emergency room, you can see, came in 26.5% above budget, and ancillary services came in just below budget by $2.8 million. And a lot of that was driven by some of the trauma pieces. Looking at our preliminary payer mix, it seems to be more favorable than the previous month. Government sponsors made up 71.1% of total gross revenue. This was favorable to the fiscal year 25 budget of 74.7%. You can see that Medicare was down at 47.9% compared to the budget, and Medi-Cal, was up at 23.2%, 2.5% over budget. Our HMO gross revenue revenue was 3.6% of total gross revenue, favorable to the budget of 1.7%. This is also higher than prior year's percentage of 1.9%. Our PPO gross revenue of 21.2% came in favorable to the budget of 20.7%. Private pay gross revenue was 2.8%, which was unfavorable to the budget of 2%, and TRICARE came in at 1.3% of gross revenue, also unfavorable to the budget of 0.9%. Moving on to our FTEs, productive FTEs for December were favorable to the flex budget by 77 or 5.3% at 1,462.4 FTEs. Also then looking at non-productive FTEs for December, they were unfavorable, but given the holidays, in terms of knowing that, it came in at 26 or 11.9% over budget at 216 FTEs for non-productive. Looking at our total FTEs, adjusting for volume, total FTEs were 52 or 3.1% favorable to the flex budget. Total FTEs per adjusted occupied bed came in at 5.77. This was unfavorable to the budget of 5.70 by just 0.07 or 1.1%. Radiation Oncology Center, the Radiation Oncology Center was busy this month. We had 435 treatments, which was 93 more than the budget of 342 or 27%. Year-to-date treatments were 2,171, which was 61 treatments or 2.7% unfavorable to the year-to-date budget of 2,232. Going to the next page, you can see also in December, the Radiation Oncology Center received 38 new referrals that came in from various sources, and also new patients seen in the clinic were 26. We had a December conversion rate dropped a little bit to 23.68%, but a lot of that are individuals still getting through their process in terms of coming, seeing other physicians and getting other treatments. So we should see that increase. Moving on to Washington Township Medical Foundation, clinic visits of 14,938 were unfavorable to budget in December by 1,823 or 10.9%. In terms of that, with primary care, we saw visits under budget by 16.3%. We do have one provider that has left in terms of Warm Springs that is impacted, but we do have another physician that will be filling that position. So Warm Springs was down 211 visits, and we also had additional physicians that had taken time off in those areas. Specialty clinics for the visits were unfavorable to budget by 5.1%. And in terms of seeing, we do have a couple of, one person in women's health that was on a extended leave that impacted that too. The other thing is to mention that we have the Masonic Home Clinic. We no longer have a nurse practitioner there, so that those visits of about 175 are no longer being there too. A lot of times now, patients will come to the actual clinics when needed in terms of it. We've worked with them in terms of being able to transport them that way. Looking at our outpatient statistics, DevCo outpatient visits of 2,060 were unfavorable to the budget by 126 or 5.8% for December, but 213 or 11.5% more than the prior year. We had WASP cases were unfavorable to the budget by 41 or 7.9%. We did see WASP close down 4 days versus what had been budgeted as 1 day given the number of holidays. PSC cases were favorable to the budget by 18.3%. And then Washington Outpatient Rehab Center visits were below budget by 6%. A lot of that had to do with physical therapists that were out ill or were on holiday too. We also had a traveler that ended one contract and started another at the end of the month. So we hopefully will have full staffing in January. Moving on to our key financial statistics, our days cash on hand for December ended at 124 days, an increase of 5 days from the prior month. As mentioned in the past, in terms of our, we did receive our rate range contributions. If you remember, we had to do the IGT transfers. We received close to $20 million from Alameda County or Alameda Alliance for rate range, and we had done an IGT transfer of about $8.3 million or so. So that has helped our days cash on hand in terms of it. That was the main driver. As you can see, there was 276 in charity care, bad debt adjustments in December of 2024. It was down from the previous month. Then lastly, in terms of our unhoused patients, total reimbursement cost for the period July to December for the 6 months is approximately $4.6 million. For 6 months from July to December, there were 1,106 patient encounters, representing 585 unique unhoused patients. Of the 585 unique patients, 184 had multiple encounters with the hospital. And those are the statistics for December. Any questions? All right, I'll move on to operations. I'll start with the employee of the month, or the calendar, I should say. Our employee of the month for January is Darlene Godfrey. Yes, I think many of you know Darlene. I will say she's worked in a number of areas throughout the hospital. Darlene has been with us for 29 years. She's working in various departments: 3 West, emergency room, outpatient diabetes; 5 West, telemetry, special care nursery, COVID unit, central surveillance unit, and the infusion center. She's also held various positions as nursing assistant, transporter, unit clerk, business assistant, LVN, and now she is the employee health specialist in employee health services. In all her roles, she has always exemplified the patient-first ethic. Darlene has helped with the Employee Health Annual Blitz since October of 2016, while working in telemetry as a unit clerk. During the pandemic, she worked in employee health services to assist with COVID tracking. Darlene has been with Employee Health since August of 2022. She is excellent with the new hire onboarding for medical clearances and is well cast for her role. She always goes above and beyond the call of duty to ensure that she is providing an optimal experience for our new hires. She consistently greets the new hires with a welcoming, embracing smile and processes them efficiently and effectively with positive high energy. In January of 2023, when we brought the new hire physical evaluation drug testing in-house, Darlene was the perfect person to manage the new hire medical clearances. She continues to assist with COVID exposure and contact tracing, and is now learning the employee injury workers' compensation case management. I think we all agree she is dedicated, consistently reliable, hardworking, and strives to provide quality work on a daily basis. Congratulations to Darlene. All right, now moving on to the calendar. We just have a few events given all of the holidays. All right, just going back to past health promotions. On December 12th, you can see that we hosted a nutrition education booth at Thornton Middle School, and there were 1,000 students that attended the wellness fair. On December 18th, Dr. Prasad Kata, our endocrinologist, did a Facebook and YouTube on diabetes management, how GLP-1 medications work, and to date, we've had over 900 views, 929. And then in December, do want to mention that our employee association hosted a drive for warmth, and we collected 16 bags of coats and blankets for the Viola Blythe Community Center in Newark. You can see some of those pictures. As you can see, we have a number of upcoming health promotions tonight. We did have one of our internal medicine doctors do education on New Year, New You, essential health screenings for every age on Facebook and YouTube. Christy Caracappa, our health insurance information service, is out in our community talking about advanced directives and Pulse. We've got Dr. Rajiv Saigal, our neurosurgery physician, who is talking about understanding low back pain on Facebook and YouTube on January 22nd. January 28th, Dr. Jean Huang, our endocrinologist, is talking about diabetes education at Acacia Creek And then on February 12th, Dr. Harsh Agarwal is talking about the Watchman procedure, a new approach to stroke prevention on Facebook and YouTube. I just want to continue to mention we've raised over $11 million for the UCSF Washington Cancer Center. And also we have the Foundation's annual meeting that will be taking place on January 28th at 4:30 p.m. And lastly, our Foundation's 38th annual golf tournament is scheduled for Monday, May 12th at the club at Castlewood. Yes, I think there was some challenges with scheduling, so I think that's what we're looking at. Just looking, I know they were just checking some schedules now. All right, I think we have one action item.
Thank you, thank you. Jeannie, would you
Sure.
present the action item, please?
Mr. President, I move that the Board of Directors accept the bid received from Webcor as the lowest possible best value bidder for the infill project, and direct the Chief Executive Officer to enter into and execute the necessary contractual documents to complete this project, with exceptions noted for payment and performance bonds. And also to direct the Chief Executive Officer to return to the Board within 60 days with recommendations for an infill project budget amendment that will provide adequate contingency for the infill project.
Second. Thank you. Would you comment?
Yeah, I just want to remind the board that in June, the board did approve the budget for Morris Hyman Critical Care, and also in August approved the Resolution 1266 for Best Value Contractor Selection. We did have 5 pre-qualified general contractors for the project, that 4 of them, 1 declined, so we had 4 that actually put in bids. As part of the Best Value Contractor Selection, interviews were held on November 4th and 5th, and all 4 contractors were assigned Best Value scores by the hospital construction team on November 6th. Bids were opened on November 7th, and the bid evaluation period did take several days, as one of the bids had qualifications in it. Because of this, only 3 of the bids were found to be complete. Excel Construction's bid was deemed unresponsive and disqualified. And then the Best Value scores were shared with all the bidders. After careful review of all the submitted bidders and the contractors accompanying Best Values, it was determined that Webcor of San Francisco, California is the most responsible Best Value bid for the project. We did send a notice of intent to award, went to all bidders on December 12th. I do want to mention that Herrero Builders prematurely filed a protest to the intent to award. After correspondence between Herrero's Builders and Washington's legal counsel, they retracted their protest, and so the issue is resolved. Yeah. As we know, the board approved a total construction budget of $52,171,229,000, and Webcor's bid does fall outside of that amount. So, as mentioned, we will be coming back to the board in terms of a budget amendment once we've had some time to look at some potential value analysis work that we can do. So, with that, it is requested that the Board of Directors, as mentioned, accept the bid received from Webcor as the lowest responsible Best Value bidder.
Thank you. Okay, we have a first and a second.
Just a second, and then roll. Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eaton?
Any other
No announcement.
items for?
Nope.
Okay. All right, well, we're going to adjourn to closed session then. Before we do that, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions. Thank you. The board will now adjourn to a closed session.